let's shift gears. Second line, I want to do this kind of quickly. We have 3 VEGF inhibitors approved in second line. We actually don't have any EGFR inhibitors approved in second line. We have them on guidelines in second line. So what's your various approach? Richard, I'll start again with you, to use of biologics, and I'll make it a RAS wild type patient in second line, just quick.
So once again, it has to be individualized, and not everybody in second line will get EGFR or bevacizumab. There's data to support using anti-angiogenic agent beyond progression. Obviously, there's some data with using EGFR, even though there is no OS data on it. So it really depends on the patient, how they progress at the first line. For example, if they're KRAS wild type and they progress within 3 to 6 months, which I call rapid progressor, then I would change the backbone, I would change the the biologic. However, if they're on FOLFOX or 5-FU bev for 2-3 years, because of the, once again, the toxicity associated with EGFR, I would just continue bev and just change the backbone.
And everybody pretty much agree with that summary? No, what do you want?
No, I mean...
He's just a problem.
It's the Ohio State.
No, and again, I think it's a reasonable approach, but I'll be frank with you. I mean, since most patients actually respond and have a durable response, that's what most patients in the first line do, I go with FOLFIRI, bev, and at progression, if they're RAS wild type, I actually just switch the biologic and keep the chemotherapy backbone the same.
Okay.
So it's not, and again, it's not better, but I just find it simpler just to continue with the same chemotherapy backbone, flip the biologics, and leave FOLFOX to third line.
Yeah, there's more and more evidence around EGFR beyond progression and re-challenging, but it's not really been a big U.S. effort. We've been more second, more third line with EGFR.
Well, we have evidence that continuing bev into second line improves survival. And we don't really know that giving EGFR antibodies sooner improves outcome.
And who would have ever thought that bev would be the bargain among the VEGF inhibitors? So, right, we have aflibercept, we have ramucirumab. Is there any, I mean, they're approved in this setting. Is anybody using those routinely? I still see a lot of folks in community, using those as single agents in the refractory setting because they're out there, because they get them approved. Anybody would support that as an approach?
I mean, only reason I would change the biologic in terms of the VEGF, different VEGF, would be, once again, same scenario where you give FOLFOX bev, they progress rapidly after 3 months, and they're KRAS mutant. Then I may change a different VEGF inhibitor, knowing that the mechanism is a little bit different. Once again, there's no data to support this, once again, but just the caveat is that if it didn't work, FOLFOX bev first line is a very poor prognosis.
That's your 5%, right? 5% or less of your patients will ever face this scenario, and those technically do worse anyway.
Yeah, anyway, I agree.
I mean, do you ever get any mileage from switching the VEGF inhibitor?
Well, there's no data.
How do you know?
Yeah.
So the more and more we're doing biopsies and molecular profiles, the more, at least I'm seeing, changes in RAS status. Both directions, actually. So like in breast cancer, they routinely repeat biopsy around HER2. Should we be doing that in colorectal cancer?
So I've been repeating biopsies as patients go down the line of therapies, and the question is it the same lesion you biopsied? Has the tumor itself actually changed? And this is where the liquid biopsy question comes in, though I don't know that it's, even though we have commercial assays available, that it's ready to make decisions on. But certainly the more progressed patients get, we'll check the tumor again.
If I have a RAS wild type, pan-RAS wild type in the bank, should I repeat biopsy or can I go?
I don't think there's any evidence that you absolutely have to change it. Realizing that what we do know is that patients who got an EGFR antibody who become resistant will have evidence of a RAS mutation where they didn't previously. But that's different than your patient because you're talking about a patient who hasn't gotten an EGFR antibody yet.